Welcome back to Revise Med. I am Dr. Rahul Vijayan. We will be discussing a small topic today, that is palindromic rheumatism. I am in a travel for a conference, so we will see this session through this a new template. So let's start this session. What is palindromic rheumatism? Palindromic rheumatism is a rare episodic form of inflammatory arthritis characterized by sudden transient attack of joint inflammation that resolves completely without permanent joint damage. The most important concept in palindromic rheumatism is there is no permanent joint damage, that is, there is no erosion in the joint. Its palindromic nature means the symptoms appear and disappear and reappear. It occurs as an unpredictable manner, that is palindromic rheumatism. One of the most important differential of palindromic rheumatism is gouty arthritis. It's mimic gout. So why this palindromic rheumatism is very important for a rheumatologist or a physician is 50% of palindromic rheumatism patients can later turn into rheumatoid arthritis. Historically, palindromic rheumatism is thought to be a precursor runner of rheumatoid arthritis. This is the person Philip Hench, along with Edward Frank Rosenberg, described palindromic rheumatism. Hence, palindromic rheumatism is also known as Hench-Rosenberg syndrome or Hench syndrome. This is the image of Philip Hench. So, coming to the prevalence, it is 1 to 5 per 1 lakh population. It is typically seen at the age of 30 to 50 years and predominantly seen in female patients. As we already told, 30 to 50% of palindromic rheumatism patient eventually develop into rheumatoid arthritis. So what are the predictors in which you can tell that this patient who is presenting with a palindromic rheumatism in later will turn into rheumatoid arthritis? The predictors for this progression include ACPA or anti-CCP positivity and RF positivity, frequent attacks, that means the patient's number of frequency of having the attack is increasing, then longer disease duration, that means the active disease period is getting longer, and evidence of subclinical synovitis on imaging. If there is an evidence of erosion is there in imaging, then that is not palindromic rheumatism. That is against the diagnosis of palindromic rheumatism. That means the patient is already having an erosive arthritis, which is not a palindromic rheumatism. It can be an RA, fully developed RA. So coming to the pathogenesis of palindromic rheumatism is quite unique because it consists both the features of an autoimmunity as well as an autoinflammatory disease. We have told that 30 to 50% of patients will have RF positivity and ACP positivity, same as RA. And these patients also who are having genetic involvement, especially HLA-DR-B1 shared epitopes as in case of RA, if these patients who are presenting with palindromic rheumatism is having these shared epitopes, that is HLA-DR-B1 epitopes, they are more prone for developing RA in the later stage. Similarly, in case of autoinflammatory pathologies, there is an evidence of dysregulated innate response in case of ACPA negative patients. These, when you're talking about the triggers which can precipitate the palindromic rheumatism, stress, infection, trauma are reported, but we don't know exact precipitating factor which is precipitating the palindromic rheumatism. So coming to synovial pathology, if you are aspirating the joint during an active inflammation of a palindromic rheumatism, you are going to see neutrophilic infiltration similar to any inflammatory arthritis, and there is no erosive changes in the imaging. So clinical features can be divided into intra-articular and extra-articular. So intra-articular means joint involvement. It usually presents as sudden onset monoarthritis or oligoarthritis, which mimics more like a gout or psoriatic arthritis. Commonly affects the small joints of hands and feet, knee and wrist. And the attacks last to hours to days, especially it lasts less than 3 days. For 72 hours, and joints return to normal between the attacks. And other manifestations include periarticular inflammation, that is swelling, tenosynovitis, erythema, and extra-articular involvement like transient skin nodules, Raynaud's phenomenon, fatigue, and systemic symptoms are quite rare. So how you can approach or diagnose palindromic rheumatism means, if the patient is having a recurrent, sudden onset, self-resolving arthritis with no residual joint damage or deformity, and if all other probable diagnoses are ruled out, then you can say that patient is having palindromic rheumatism. For assess the progress of the disease, you can do RF and ACPA, often positive in 30 to 50% patients, and ANA may be weakly positive, and ESR and CRP will be elevated during flares and will be normal in between the disease. And if you are aspirating the synovial fluid, you are getting an inflammatory neutrophil predominant synovial fluid. And imaging, ultrasound may show subclinical synovitis or effusions during the attack, and radiographs are typically normal and there is no erosions. So how you can treat palindromic rheumatism means, acute attack is usually managed by NSAIDs as first line for pain and inflammation. You can also try colchicine because the pathogenesis of palindromic rheumatism is somewhat overlapped with autoinflammatory diseases also. So colchicine also will have some response in these cases. And the preventive treatment and or the drug of choice which all should get is the HCQ. HCQ is the most common DMARD used in case of palindromic rheumatism. It reduces the attack, it prevents rheumatoid arthritis progression, and methotrexate can be considered in palindromic rheumatism subset of patients who are positive with the antibodies suggestive of rheumatoid arthritis, because in probability of having rheumatoid arthritis in the future is very high in these patients. And if the patient is having frequent attacks and evolving an erosive arthritis, also methotrexate is indicated in these patients. So what is the differential diagnosis for palindromic rheumatism is early onset RA, crystal arthropathies such as gout, pseudo-gout, reactive arthritis, autoinflammatory syndromes, especially FMF. FMF will also present as monoarticular pain and joint pain.